Dr. Kish, good night. Good night, my friend.
Good night means I should sleep now, right? Good evening, good evening. Hey, how do you share the screen here?
Yes.
How do you share the screen?
Just.
All right, okay. Where is my presentation gone? Okay. And okay, this can be closed. Here. Pablo, can I just check my screen if you don't mind?
I don't look your screen.
Yeah, can I check it? Share
okay.
now. Screen one, share.
Okay.
And you are presenting to everyone.
Yeah. Okay. I saw now.
Are you able to see the presentation?
Yes.
And it's okay for you?
Yes.
Awesome. Okay, fine. So I will just wait for you to give me the notification and I can stop presenting for now. Perfect.
How are you?
I'm okay, man. I'm good. Not sure what the future of things is. How are you doing?
Fine.
You're not very clear.
The weather.
The weather, it's very dark outside. It's cold. I know you're in summer right now.
Here is summer every time.
Yeah.
Boa noite, pessoal. Leonardo, Nina.
Boa noite, Dr. Pablo. Tudo bem, pessoal? Nina.
Tudo bem?
Boa noite a todos. Vocês estão me escutando bem?
Estamos sim.
Certo.
Dr. Kish está aí a postos.
Good evening, Dr. Kish.
Hey, good evening, tudo bem?
Tudo bem?
Kish, do you have a course, no? Clinical course. Can you?
Sorry,
Can
which
you
course?
speak about? You have a foundation course, huh?
Oh, yeah, that's for junior doctors, not for radiologists. It's very basic.
Ah, okay.
Yeah.
Ah, great. It's virtual course. Oh,
Yeah.
it's yeah.
Everything, all systems.
Yeah. Okay. Good evening, everybody. I would like introduce Dr. Kish Mankad, my friend, my great friend, a great neuroradiologist in the world. Thank you for accepting my invitation. We are very happy with you here. Talk to us. I'm very happy for this. The lecture is Diffuse, Glioma, Midline. Dr. Kish, please.
Okay, just to confirm, you can hear me out and see everything that you have to see, correct?
Yes.
Awesome. Okay. Hello, everyone, in my favorite country, Brazil. And it's a small club I can see, so I like the eliteness of the club. I will speak a bit slow, but if there is any problem at all, it's a new platform for me. So, Pablo, you can please unmute yourself and say whatever you have to say, okay, in case there is any problem. Okay.
Okay.
Thank you. It's a very interesting topic, and I think it is a topic that took me a lot of reading to understand it, even for a radiologist. And I hope I will add some value. Thank you very much for joining. Some friends of mine, I can see Dr. Leandro Lucato, Dr. Leonardo, Dr. Furtado as well, and of course my friend Pablo. So let's kind of study together, and we can have a discussion in the end as well. If at any point anyone wants to interrupt me, feel free. This is going to be an update on diffuse midline glioma, an entity that was described for the first time in 2016, so pretty recent. And that happened because of the discovery in 2012, just 4 years prior to the last WHO revisions to the brain tumors, where the particular mutations were discovered in the histone proteins. So as radiologists, we are still doing the catch-up game, and we need to understand what exactly all this means, because we have a tendency to call a lot of things diffuse midline glioma just because of their location. So let's try to work our way into understanding the core of this, apart from radiology, a little bit of how the pathologist sees this, and a little bit of what is the future of this particular dreadful disease. Now, as a warm-up, I'm going to ask you a question. And unfortunately, at the moment, I will struggle to see your answers, but perhaps I can keep my room open here on the side and the chat function as well, so we can look at some answers coming up here. And my question to you is, what is the median survival of DIPG? And this is diffuse intrinsic pontine glioma. So the traditional name of DIPG is still hanging around, and it was converted to DMG with the advent and discovery of certain mutations around 2012 AD. And whilst you're thinking, this is a piece of reflection just to get your attention. The correct answer of this actually is a dreadful 11.2 months. And this is the evidence to support it, where a large population study was able to confirm that the median survival of DIPGs centered in the pons is actually less than 1 year. Which means that whatever is done for these tumors, they basically end pretty badly and pretty quickly. Why is this the case? Why is this tumor such a killer? It all started in the pons. So we know that DIPG exists in the pons. So really my second question to you is, which of these three entities, A, B, and C given here, represent a histone-mutated diffuse midline glioma? And you can see that all these tumors are centered in the brainstem, particularly involving the pons in different fashions. The reason I ask you this question is because DIPG is one diagnosis which the radiologist should make based on clinical criteria, where patients present with cranial neuropathies or deterioration in gait, and it's pretty rapid deterioration. Not many centers biopsy the entity of DIPG, and in fact rely a lot on the radiologists. But if the radiologist picks up any atypical features, then they are duty-bound to ask for a biopsy and other investigations. So if you can figure out where the chat room is, and you can look at the chat there, I think Ivan has put some messages there. Just for a feel of things, which of these would you consider as histone-mutated diffuse midline glioma? And basically save a biopsy if you have to, and start the patient on radiotherapy because the treatment is going to be palliative. And let's look at these three entities. So the first entity is exactly a tumor that has completely engulfed the basilar artery there, which is basically completely encased. It's quite low on ADC. It's a bit diffuse and spreading into the rest of the brain. It's not restricted to the pontine region as such, and you can see some exophytic elements. On contrast, it's not really showing any enhancement of significance, but very low ADC values. And when you see a tumor like this, bright on T2 weighted sequences, very low on ADC, not picking up much in the way of enhancement, that means there's not much in the way of breakdown of blood-brain barrier, you're going to call this, until proven otherwise, an embryonal tumor. And in 2021, you will confidently call this an ETMR. This tumor here, a bit eccentric, presenting with a lot of necrosis centrally, centered on the hemipons, not really doing much to the basilar artery out there. And you can see there is heterogeneous diffusion change and heterogeneous enhancement as well, is what people would have traditionally called as a high-grade glioma or a glioblastoma multiforme. The third case here is actually doing what your typical DIPG would do. The tendency to just go and hug the basilar artery, eventually it will kind of go around the basilar artery. This is trapped, this is engulfing. And it has got a homogeneous texture. On the ADC values, by and large, they are low ADC values, but some areas which are more anaplastic probably, or showing some low ADC values. And the enhancement is not here, not there. By and large, maybe a little focus of enhancement in the middle, and that might relate to some focal anaplasia or necrosis. So 3 different tumors centered in the pons and presenting in 3 different ways. As a summary, not everything in the pons is therefore a DIPG. And I think where you have to call something atypical, it should be biopsied, because all 4 different entities are basically managed in different fashions. I will let you absorb that for a moment. Just kind of absorb it and reflect on it, because we do see pontine tumors, and we have a tendency to call a lot of them DIPGs when we should not, unless they're following pretty simple rules. Which then brings us to the question as to what exactly is a histone-mutated glioma. And that is a very relevant question. I think radiologists need to understand. We have so far not even understood what the word glioma means. Let's pick up a little leaf from there and look at what histones actually imply. Now here is a video animation, and I'm going to speak as the video moves. And this video animation basically goes back to the eukaryotic cell and right into the nucleus, where you have the double helix of the DNA. And this double helix of the DNA is a long, around 2 meters of DNA in each of your 10 trillion cells kind of structure. It has to be packed inside the chromatin. So here comes a lot of proteins. These are the histone proteins, usually a complex of 4 to 5 proteins. Some people have even discovered 8 histone subtypes. And these proteins are actually packaging proteins. And the chromatin wraps around it, becomes molded into a compact nucleosome. And the nucleosome further forms the chromatin mesh, which is in the nucleus containing all the DNA, all the information, and you can see these hair-like projections are actually the tails of the histone protein. Now that is at the ultrastructural level, what histone proteins do and their function in terms of integrity of the chromatin and formation of the nucleosomes. What happens when the histones start misbehaving? So here is the core protein. I did tell you there were usually 4 basic subsets. One of them is a histone 3. The others have 1, 2, 3, 4 numbers. And essentially, in the post-transcription phase, because once the histone has been laid by transcription, it undergoes epigenetic modifications. The epigenetic modifications could be either methylation and or followed by acetylation. In fact, both processes happen. Methylation packs up the chromatin closer and prevents the DNA from undergoing further changes. Acetylation, also an important process in the post-translation and transcription histone modification, opens up the DNA a bit and allows it to express it, because the DNA areas will only express when they are exposed. If there is an imbalance in any of these processes, usually it's an undermethylation that happens in the H3K27M mutants, you're going to have problems. And the problems essentially imply that the H3K27M mutants induce defective chromatin spread. And when you have a defective chromatin, that gets susceptible to rapid tumorigenesis. And that balance between the oranges and apples is very important. Hence, the gene that is affected is the H3F3A. The problem is that amino acid or codon, transcodon 27, which is getting replaced by methionine instead of lysine, or it can happen in amino acid 34, where glycine is replaced by valine or arginine at the amino acid level. Other associated mutations can be discovered quite commonly in the context of this mutation. So in summary from that, histones are basic proteins that associate with DNA in the nucleus and help condense it into chromatin. And when we talk about the H3K27M defining mutation of diffuse midline glioma, we are basically talking LIS for lysine, 27 for the position, MET, which is basically what is being replaced by methionine, mutation in the histone 3 genes. And histone 3 is one of those 4 genes which basically forms the core of the histones which supports the DNA. And overall, a decreased methylation leads to the problems. And hence, the H3K27M mutation is a defining trait. Now, C-Impact now is a group of professionals, mostly pathologists, geneticists, who get together on a regular basis and decide what should be the clear nomenclatures, classification systems, and kind of then that leads on to iterations, then leading on to further revisions to the WHO criteria. So the C-Impact now has had around 6 or 7 iterations, but the second one, which was an update on diffuse midline gliomas, clearly described it as an infiltrative midline high-grade glioma of predominantly astrocytic differentiation and a K27M mutation, which could happen in the pons, thalamus, or spinal cord. So these are the 3 locations where you can get this. But the 4 elements of the diffuse, midline, glioma, as well as this mutation are essential to making a diagnosis of DMG or diffuse midline glioma. What do we see in histopathology? Just to understand the biology of this tumor on imaging, which is quite diverse and maybe non-specific unless you really start thinking about it, it's good to know what is the cell makeup of this tumor. And here we have an H&E or a hematoxylin and eosin stain, which basically shows moderately cellular glial tumor of relatively monomorphic. You can see monomorphic nuclei out there, look pretty standardized. Out here, you have the immune histochemistry looking at the GFAP, or the glial fibrillary acidic protein, labeling of cells which are arranged around glial fascicles. So the GFAP is strongly positive. We know that there is a glial origin, there is a glioma here. Now these become a bit more interesting. You are looking also for the ATRX, which is a subsidiary or an associated epigenetic phenomenon, whether ATRX is being retained in these cells, as in those brown ones there, or it is being lost, as in those blue cells. And finally, you can code specifically on immunostaining for H3K27M antibody, which detects mutant protein only. So it will only detect the mutant protein. So everything that's brown there is the mutant, but the native glial cells and the vascular cells are not stained by this particular antibody. And that confirms the diagnosis of H3K27M, diffuse midline glioma. It's important to remember that whatever be the histology of the tumor, the moment you find this mutation, it becomes a WHO grade 4. This interesting paper from China looked at a population of gliomas with this mutation. Now, that had been histologically characterized initially as low-grade gliomas, anaplastic gliomas, and glioblastoma multiformes. So various kind of subsets of these low to high-grade gliomas, but the moment you find a mutation, you have to call it a WHO grade 4. And that is why, if you think about the last DIPG you might have seen in your practice, it's high on T2. It may not have very low ADC values. It looks pretty benign on imaging, but it's the mutation that changes its biology so badly. In this study, 40 of the 61 cases were also found to be TP53 positive. And you know that this is a proto-oncogene, leads to problems. Further on, people therefore started looking at the locations. Now, the location refers to embryology. And when we talk about embryology and the development of the brain, we have to think about where in the brain would the K27 actually be expressed. And apparently, in the late fetal stage, K27 expression seems to happen in the corpus striatum as well as the thalamus. And the pons is an interesting location. So all the green bits here essentially relate to K27. And you can see why the midline would be taken off, because you striatal involvement as well as involvement of the thalami is common. And we'll come to the pons in a moment, because the pons microenvironment is a bit different. You can see it in locations like the spinal cord, but I must tell you that I have never seen a primary diffuse midline glioma only in the spinal cord. And if you have seen a case, please share the case with me, because we should really be publishing that as a primary isolated case of spinal diffuse midline glioma, where nothing is happening in the brain. And if you compare this with the G34, which is the other histone mutation commonly seen, you would be looking at expressions involving the striatal as well as the cortical region. So these tumors, the G34 ones, are quite diffuse and can have cortical and subcortical distribution in the brain. And if you look at the color, you can see how much more of that purple or blue description happens on the surface or close to the surface of the brain. In the pons, the tumor microenvironment is interesting. And this particular paper talked about the cell of origin. Where does this entity called the DIPG come from? And I've told you there is an astrocytic, there's a glial proliferation, but what's driving it? And apparently the cell of origin here is still oligodendrocytic. Now, don't forget the oligodendrocytes are also glial cells, and they are supportive cells as well. And in that context, the oligodendrocytes are relevant. And this fact has been supported by the overt expression of essential factors in the specification of oligodendrocytes, like the PDGFRA, the OLIG1 and OLIG2 upscaling that happens in the context of these tumors. The EGFR is also relevant, which is the epidermal growth factor receptors are also upregulated. Why do we need to understand this? We need to understand this because at the moment, the research is about targeted therapy. We're looking at EGFR inhibition. We're looking at inhibition of these receptors like the PDGFRA or the ACVR, etc. We're trying to make sure that the tumor becomes radiosensitive, because this is not a radiosensitive tumor. So all these targets are relevant to understanding what is being done to these tumors at this point in time, and the radiology will follow that. So really, as purity of terms, remember, don't use the term DMG for anything that is in the thalamus or in the spinal cord. The commonest spinal cord tumor is still going to be a benign astrocytoma. The term is reserved for those with this mutation, and that is very clear. So here is an 11-year-old boy and who presented with diencephalic syndrome, was biopsied elsewhere. You can see a little bit of biopsy tissue taken off from there. So ignore this little signal changes secondary to biopsy, but very much in the thalamus. Now, we think of the thalamus as one structure. The reality is that the thalamus has got 8 nuclei, gray and white matter sitting on both sides. Anyway, it's taking off the entire macrostructure of the thalami on both sides. And when you have a picture like this, generally in referring hospitals, people start thinking about encephalitis. And this child was sent to us with a diagnosis of encephalitis. The biopsy was done because the child was not responding to steroids or any other form of treatment. And here you have the T2, the flare, the post-contrast. You can see not much in the way of enhancement. These are not those tumors that proliferate because of breach of the blood-brain barrier. They don't need to break the blood-brain barrier. The proliferation is happening at the oligodendrocytic glial level. And on the ADC, some areas which are a bit low, but not overtly low, not like the ETMR that we saw. Of course, I have minimized the spectroscopy here because I really don't want you to spend too much time doing spectroscopy on all these tumors. You will be caught out. In fact, this was called as an inflammation type of spectrum, and they didn't pick up neuronal loss. They didn't pick up a very high choline. So it was completely mismanaged spectroscopy in this particular case. The biopsy eventually, of course, showed an H3K27M. The key message is whenever you pick up bithalamic lesions, have a very low threshold to think about a histone-mutated diffuse midline glioma. Remember, embryologically, the thalamus, the striatum. Now, the striatum is interesting because we're not picking up much tumor out there, but we've seen cases where it spreads around the rest of the ependymal margins of the ventricles. 2 cases here, and both indeed of a proven H3K27M diffuse midline glioma, and this in the context of NF1. Now with NF1, you expect to see very benign tumors. So this was a bit of a surprise, and we do put our surprises together. Here in the thalamus, centered out there, bit of peritumoral edema as well, extending to the capsular region. And this tumor actually, you can see nicely extending to the striatum, behaving as it would, as its embryology should dictate. Little bit of intrinsic hemorrhage because that is pre and post contrast sequences. It's not really picking up much in the way of enhancement again, and the ADC values are low out here. This was an 8-year-old girl, and this is a 16-year-old boy. Again, a thalamus-centered tumor, this time quite diffusely involving the rest of the hemisphere on that side. I put an ADC cursor here. It is showing around 813 as minimum. If you start picking up medulloblastomas or ETMRs and other supratentorial kind of high-grade tumors, you might get even lower ADC values. But it's important to actually look at these readings and try to make sense of it, and I'll tell you why in a moment. So when you encounter thalamic tumors, think histone mutations, especially when your ADCs are a bit intermediate. The tumor is not picking up much in the way of enhancement, and it looks rather astrocytic on the T2-weighted sequences. Left untreated, this patient had an initial resection. This is our 8-year-old girl again who had the big thalamic mass in the NF1 population. This tumor then infiltrates and diffusely metastasizes to the leptomeninges involving the spinal cord. So we do have a case of spinal cord H3K27M mutant dissemination, but this is not a primary spinal cord tumor. This is disseminated at this point in time. And just really whilst we are there, also look at bony deposits. You can pick up bony metastasis and skeletal metastasis in the context of diffuse midline gliomas, just like you would see in certain medulloblastomas, attaching credence to the theory that the dissemination of these entities could be through CSF as well as blood. And there is an emerging base of case reports around this. We've had a couple of cases where we have seen mets to the vertebral bodies as well of the spine. But the differential is wide. You know, as a radiologist, we are not expecting you to pick up the integrated WHO diagnosis and the pathologists lose their job. That's not the aim. Like in this case, you know, you have a big thalamic tumor. And in fact, this was reported initially as a diffuse midline glioma associated with the right thalamus. Not bad, but what was misinterpreted initially was the fact that they already have something else going on in the periphery out in the subinsular region, which at the moment should not be interpreted as obstructive hydrocephalus related CSF seepage because it is nowhere close to the periventricular white matter. Yet the primary tumor could look like a histone-mutated glioma, as you can see, except that we are not expecting this dissemination to happen at this point in time unless it is contiguous, and it is not. This turned out to be an IDH mutant, which is not a typical thing seen in children. You can see this child is almost 17, 18 years of age, and this was a lower intermediate grade tumor, as you can see in this case. Much against this particular patient, 9-year-old girl who has an anaplastic grade 3 astrocytoma and did not, we have to still particularly, this is a histological grading of this tumor, we still have to go and look hard for a histone mutation. In this case, it was negative. And it's a difficult case. We are not asking you to guess whether this is histone or not. I'm showing you the spectrum of possibilities that happens. Of course, if you have a picture like this where you have a fluffy mass and your enhancement pattern is such as if somebody has taken a picture of a cloud or it's an out of focus kind of edge, and this is still in the thalamus but extending out all the way involving the basal ganglia structures, this turned out to be a BRAF-fused pilocytic astrocytoma. So a lot of entities can happen in the thalamic region, and I'm showing you more thalamic tumors at this point in time. We will switch to the DIPGs in a moment. One more companion case, this time a rather hemorrhagic, aggressive-looking tumor. You can see there is heterogeneous enhancement. You can see the T2 low values consistent with hemorrhage, has presented with hydrocephalus. By this time, the surgeons had put in a drain, but this turned out to be a pilocytic xanthoastro with an NTRK fusion, which is actually a low-grade glioma. This did not have a histone mutation. So different possibilities exist. And really, whilst you're thinking about the thalamic cases I've just shown, there is a philosophical point I would like to mention here. Thalamic tumors are dangerous because the surgical access is very deep. Surgeons would like to know as much as possible about the tumor from their radiologists before they can get in. Because the moment you start thinking about invading the brain to attack the tumor, you're going to cross the internal capsule, you're going to risk a hemiplegia, and it's not easy. If we are a bit confident about this is definitely low grade, don't worry about it, maybe they will get out a pinch of biopsy of tissue and come away and get the diagnosis, and the patient could be subjected to ancillary integrated therapies. If we think this is going to be a high-grade tumor, definitely we need to get the tumor as much as possible out, because overall survival of brain tumors is still dependent on the best surgery that has been done. Then our surgeons will be a little more aggressive and try to get most of it out. But the thalamus is not an easy place to go to, and therefore we have to do that much justice to our surgical colleagues. Going back to 2016, and I must keep a tab of time here as well, but going back to 2016, the 5 basic clusters of tumors were such. You can see that there is an intrinsic problem, and I'm sure that in 2021, when the revisions come out, these entities will start becoming a little more clear and distinct from each other. But the diffuse midline gliomas were thrown into this box of diffuse astrocytic and oligodendroglial tumors, whatever that means. So we're going to focus on this box here, and very helpful slide made by my colleague, Dr. Lobel, who works with me at GOSH, very nicely tells us what exactly is happening in the spectrum. So let's start with the diffuse astrocytoma, the glioblastoma multiforme, the oligodendrogliomas. They are mostly seen in a lot of kind of wide spectrum of adults and young children or older children, but you're looking for an IDH mutation, not very common in young pediatrics. And then based on their 1p and 19q co-deletion or the IDH wild type kind of situation, we would characterize these tumors. The moment we pick up the H3K27M, we're talking diffuse midline glioma. And the other associated features, as we have described, can happen. Now, this is the same patient, and I'm going to keep running the ADC a little bit. Just focus on the contrast picture here, if I can run this again. And I'm going to show you the flare out here. Quite a diffuse, ill-defined tumor. Now, you're not going to call this a diffuse midline glioma because this is diffuse. It may be midline, but we haven't proven the exact mutation yet. In fact, it turned out to be histone negative, IDH wild type, yet a high-grade tumor. And I've seen a lot of high-grade tumors, IDH wild type in children, where they don't enhance. They may show a little bit of low ADC values, but not particularly. Sorry, that's going quite fast. But on the flare, you see a diffuse encephalitis kind of brain. So remember this entity. This is what we used to call gliomatosis pattern of spread, but they may not have any of the mutations that we are thinking about. Just a recap of those cases. As a corollary or a companion case is this case. Now, we talked about H3K27, and I told you that the G34, where the problem is the glycine replacement that's happening with valine or arginine, is the other histone mutation, being kind of the second commonest, I would say, but not as common in children, is this entity. In this child, which you pick up as diffuse cortical subcortical changes. In parts, the ADC is a bit low, maybe showing some enhancement. In fact, this patient was sent to us with a diagnosis of MOG demyelination, tumor mimic, except that they did not respond to any MOG kind of treatment. And the final diagnosis in this 14-year-old boy was of an H3.3 G34 mutant. Just to recap the embryology, I did tell you the expression of G34 is striatal and cortical, and you can see how the cortex has got an abundant expression of this particular mutation. Try to understand the anatomy and basic pathophysiology of the disease. Image interpretation will become clearer. Another twist to the tale, and I thought this would be a very good message to give to all of you, is this case of an 8-year-old boy presenting with unsteady gait, dizziness, and vomiting. Now look at the tumor. It's a brainstem glioma. You must have heard Dr. Zoltan Pateh's fabulous talk on brainstem tumors a few times on a few platforms, and he never fails to impress us with the abundance of knowledge and practical tips that he gives. So let's use it and put it to practice on this case. Except there is a twist here. I've also given you an F-DOPA PET-MR. Now, PET-MR has got an increasingly important role in tumor assessment as well as response assessment once they are started on treatment. So let's break it down. You've got the axial T2s at 2 different levels. It's quite eccentric, involving one side. And it's not particularly pons, it's more of medulla and going into the cervical cord. Enhancement around there. You've got ADC values which are heterogeneous, but some really low ADC values could be picked up in these tumors. And on the CT scan, not a great picture, but maybe some high density, which is going with the ADC, not picking up much in the way of calcification. And when you give the F-DOPA PET-MR, a huge uptake. This was an SUV or a standardized uptake value of 7, which is very high. So based on this, this was given high-grade glioma diagnosis. And in fact, nobody wanted to touch this patient, except that the biopsy was recommended because the parents were pushing to know exactly what this tumor is, whether there is any hope for this patient. And a biopsy confirms this to be a ganglioglioma. Brainstem, first message with this case, if you have tumors which are posterior to the pons, in the context of gliomas, think low grades more than high grades. Pons, we know, pons will kill. Even if it looks low grade, it's going to be a histone mutated high grade. There is an abundance of low grade gliomas. This particular entity, ganglioglioma, shows low ADC values, and it can also show high SUV uptake. So when I give you a question like this, you probably are going to call this high grade, but essentially it is a low grade tumor. This is a caution. It is an epilepsy-causing tumor. It can happen in the brainstem. The problem is the BRAF V600E mutation that happens in ganglioglioma, because of which you get really low ADC values in these tumors. And the avid uptake on F-DOPA PET is because of the fact that there is upregulation of the L-type amino acid transporter. And because of the upregulation of the LAT1, there's an increased DOPA uptake. So it's actually physiological almost for that tumor to pick up the F-DOPA. So remember, it's a pitfall in PET-MR, especially when you're using DOPA to look at gangliogliomas. It's a pitfall in ADC measurements as well, because gangliogliomas will give you low ADCs. Look at this tumor back to the thalamus. I do like the thalamic area to understand these tumors. Back to the thalamus. Ill-defined, but in fact, sorry, well-defined, but not very bright on the T2. Low T2 values in the core. Diffusion shows low ADC out in the center. Bit of enhancement around the margins, but the area inside is low. This I had reported as a high-grade glioma until proven otherwise, turned out to be another ganglioglioma. So you got to keep reminding yourself that, low ADC values can happen in low-grade tumors. And it's important to put a cursor. In fact, when you start measuring the numerics of this, you will not pick up very low ADC values. This was not calcified. This was not hemorrhagic. We had other sequences to confirm that, because hemorrhage and calcification can reduce the ADC values of tumors. And then we are moving towards the important part. And I call it important because that's what makes a difference, adds value or not to patient outcomes. Let's go back to the pontine tumor. Now, very slowly, look at this case. This is a case of an early formation of what looked like some glial tumor. It's eccentric. It's not even looking very typical, but eventually you can see it's becoming to engulf the basilar artery. And this was a biopsy proven histone mutated glioma of the brainstem. Okay, so on the 4th of July, American Independence Day presentation. And this is just before radiotherapy. Radiotherapy starts on the 1st of September, so it's taken a bit of time. And the patient was discussed at multiple centers. You can see the tumor is quite small, still there. And this scan is done immediately after radiotherapy. And this scan is done 2 to 6 months, as would be standard recommendations. This patient was actually on a trial called the BioMEDI trial, which was looking at targeted therapies for DIPGs. And in that context, the trial warranted a very early scan. This was day 2 to 3 after stopping radiotherapy. So a very early scan. Now, whilst you're looking at the post-contrast sequences here at 2 different levels, I will also give you the T2 out here of the same timelines. So just before radiotherapy, just after radiotherapy out there, and 2 to 6 months, 2 months, and then 6 months after. And my question to you is, I've given you some values as well of the minimum ADCs. We looked at minimum. Minimum is better than median or average, but you should look at both. The minimum ADC falls and then it rises. And the maximum CBF, we had some CBF also on this, not shown on the pictures, but the CBF rises and then falls. Now, is this pseudo progression all along? Is this true progression all along? Do we have an initial favorable response, then pseudo progression? Do we have an initial favorable response and then progression? Because this is true to life. When you have a situation like this, and you have the benefit here of retrospectoscope, where you have all the timelines, at each of these, we struggled to decide whether this was true or pseudo progression. The patients can come with clinical deterioration even with pseudoprogression. If you look at the RAPNO recommendations, we have a slide to show you later. There's a big focus on volume assessments, and they say the volume, if it increases by 25%, then you should be calling it true progression, and there's definitely a 25% increase in volume each time out here. Except that this particular scan is immediately after radiotherapy. And if you think about what radiotherapy should do to the tumor, it would actually provoke an inflammatory response in the tumor. So we should be thinking about the situation here as some real response happening. But beyond that, the tumor continues to spread. So we're going to call this true progression. In fact, the patient died. on trial, and this trial actually did not succeed too well as well. None of the trials so far have succeeded in the context of DIPG. If you could invest your life into studying the one tumor type that would make a difference, it is this, the DIPG, diffuse midline glioma. People have looked at spectroscopy. You might wonder that spectroscopy might change. In fact, this paper from St. Jude's 2017 showed that the metabolic spectrum of these tumors actually did not change in spite of changes in its T2 characteristics or a change in its volume. So a lot of things have been thrown at it. Response assessment remains quite difficult. We started looking recently at texture analysis because textures sees characteristics beyond the human eye. Textures can be applied to T2, T1, diffusion, post-contrast, perfusion, all sorts of imaging modalities that we acquire. And textures give you a lot of output. You can see some of these outputs here, mean standard deviation, mean of positive pixels, kurtosis, diffusion kurtosis, all automatically done. And we're looking at any p-values which are significant. And we looked at this cohort of DIPGs, which was pre-2016. So they were not biopsy pro-1, which is the limitation of this paper, except that we were able to show that in conditions where the T2, axial T2 was homogeneous in its texture, this is not just human eye, but looking at the texture level, at the radiomix level, if the T2 was homogeneous, and this T2 was more relevant than ADC, survival was actually less in those patients. In fact, we were able to see a survival difference, these are the survival curves. So we saw a survival difference of 7.5 months compared to 17.5 months in two different groups. Now you can make what you want. It's dismal both ways because children are still dying within 2 years. But maybe there is hope for the longer survivors to target some more. And this is how research really starts and builds up on itself. So go back to the T2, always look at the T2 well. And if there is a definite reduction in the T2 characteristics, because these are very edematous tumors, you will get a very bright T2. You can get a very low ADC value as well, or a very high ADC value. Because it's a water-laden tissue, look at the change over time. That is more relevant. And great papers looking at the diffusion of the diffuse midline gliomas, especially in the PONS, the DIPGs. Tina Young-Hussein from Boston and friends out here, particularly Dr. Tamarazi, part of this paper. And they looked at diffusion characteristics. Now, the first group here, this is a slightly older paper, and this is from 2015. They looked at histograms across the entire tumor. So you look at the flares out here. This is an example from their paper. Look at the flares. You can see quite an ill-defined DIPG. And then you have the ADCs, and you look at the histograms. Now, patient number 1, when you have a single peak on the histogram, then apparently the overall survival and the progression-free survival is poor. When you have bimodal peaks on the histogram analysis, if you have the right tools to do it, apparently the overall survival in this patient was 900 days, and the patient and the progression-free survival was 455 days. So a big difference in these two subsets, but you can see why. This ADC is actually quite bright compared to this tumor. You can already see that on a qualitative visual analog score, but you can quantify that too. But first, I mean, low ADC is related to poor survival. That was the main outcome of this paper. And out here, the outcome essentially was comparing the DIPGs to the glioblastoma multiforme higher up in the supratentorial compartment. You can see the ADC values are really low out there compared to this tumor. And they concluded that there is not much in the way of a statistically significant difference in the histograms in these tumors, wherever they are, but the overall survival can be variable. But these box plots basically were done, and the box plots essentially show there's not much of a difference on diffusion characteristics of those which are histone mutated or the histone wild type tumors. So the RAPNO that was released last year as a set of 3 papers, part 3 was focused on the DIPG. And I think there is a lot of work still left to be done. There is a big focus on volume measurements, whatever method you want to follow. But as I just showed to you, if you're going with 25% and 50%, you might not be able to be confident as to what's happening. Just a change in volume may not necessarily mean that the tumor is progressing, depending on its time point from the baseline. But if you're not sure, and if you're not sure if it's true or pseudo-progression, you're going to do a repeat scan in a short interval. The problem with this tumor, of course, is its overall poor prognosis. Finally, a word on treatment. Currently, it's palliative. And we say we should give radiotherapy. In fact, some centers are trying proton beam therapy as well. The problem with the tumor is that it is radio-resistant. And it is radio-resistant because the H3K27M mutation renders the tumor radio-resistant. It renders the tumor radio-resistant. There are a lot of potential targets, and this is a whole list, and you're probably looking at pretty high-end publications right now, but we are going at the ultra-structural level, trying to modify those very essences of epigenetic expression. We talked about acetylation, so we can have acetylation inhibitors. We talked about the EGFR signaling that was happening. To block that could be a potential target. Some trials have already occurred, but really they haven't succeeded so far in changing the outcome of this particular tumor, the diffuse midline glioma. What therefore is our role as radiologists? First of all, and the RAP note definitely stresses on it, you have to standardize the imaging. We should be doing the same sequences, same angles, same slice thicknesses across the world, I think. And I would really hope that we can unite to provide one platform for one technique, whatever scanner you're using, because comparisons become easier, understanding tumor biology and using imaging as a surrogate biomarker becomes standardized. As radiologists, we have to define the anatomy. We have to reveal the spread. Don't miss out on the additional findings. You have to attach radiological confidence to a diagnosis of DIPG. Not every center is going to biopsy it. But if you're going to give non-specific and differentials and useless things, it's not going to benefit anyone. If there is going to be a biopsy, provide the right targets, use your ADC. If you're doing perfusion, use your perfusion, whatever you're doing, try to provide a better target because your yield is going to be dependent on that. It's a brainstem. We can't have very large biopsies. The surgeons have one go at it. At the same time, provide the safe approach. If you have to use DTI for this, go ahead and do it. Especially in the thalamic area, it might be quite relevant to look at the corticospinal tracts and make sure you try to keep it as safe as possible. Treatment. At this point in time, I can tell you that I do not report a scan or an oncology follow-up without knowing what drug the patient is getting. And you can ask my fellows and trainees that I do insist on them knowing as well what exactly is the drug doing to the tumor before we even report on the scan. As radiologists, we need to participate in trials. There's a lot of nonsense happening in trials in terms of what protocols should be used and how interpretation should be made. It's only when clinical radiologists start participating in trials and put their hands up will we be able to provide a service that is safe, standardized, and useful. And that brings me to the end of my talk. And I'm happy to take questions here. We will stay in touch, hopefully with more sessions like these for knowledge exchange and transfer of information. So thank you for listening in.
Amazing lecture, Dr. Kish. Thank you very much. Excellent lecture. I didn't see time go by. I didn't see. Excellent lecture. Question for Dr. Kish, Dr. Leonardo, Dr. Leandro Ducato, Dr. Elder, please.
I'd like to thank you, Dr. Kish, for your amazing lecture with high level as always. And in fact, I have a lot of difficulties when I'm doing this kind of reports because, as you showed, sometimes we can overlap the key images of low-grade or a high-grade tumor, and we think about the location and the age of the patient, but sometimes I have the sensation that we cannot say a lot, write a lot on our report. and we don't have confirmation of all of our cases with the histone mutation, and this feedback is very important for us to get the correct information of the tumor and to learn about that to the others companion case we will see in the future. And
completely understand.
Just one more aspect, Dr. Kish. How do you deal with this kind of tumor when you see in the adult or elderly patient? I mean, it's not so common, but we know that we have this kind of mutation in this age of patients, but it's much more frequent that it will be a GBM, for example, or anaplastic glioma. But the location, sometimes the key images are similar to the midline diffuse glioma.
That is true. The location can be midline in some of these entities which may not have the histone signature. This was a very pediatric specific talk, and in pediatrics, 80% of those midline tumors may harbor a histone mutation. Not as common in adults. Definitely, you see the other spectrum, you see the IDH spectrum. And then there are ways, I mean, if I were to do an adult talk, I would completely go on a slightly different pathway to look at those entities particularly, because there is a lot of focus on the location in terms of the hemispheric or the peripheral location, the extent of calcification, the cystic change, and then try to distinguish between the 1P co-deleted, the non-co-deleted. So we're talking a slightly diffuse, different kind of spectrum here compared to the pediatrics.
Yes.
In fact, the DIPGs, they don't last into adulthood anyway, so you should not be seeing much of that happening in the adults.
Thank you, Dr. Kish.
Hi, Kish. This is Leandro Lucato. How are you?
I'm good. I'm good.
Good to see you. Thanks for the lecture. It's really a pleasure to see your talks. And I have two questions, actually. One is at Gosh. What's the confidence that to make the diagnosis of a glioma, pontine glioma, without biopsy? I mean, when do you guys feel that there's something wrong, and then let's go to a biopsy, let's not go for a radiological diagnosis? This is my first question.
Definitely. If the tumor is eccentric and not even going towards the basilar artery, if it is very low on ADC values, if it has a lot of heterogeneous enhancement in it, I will ask for a biopsy. I might be wrong, but mostly we are right. And if they're quite homogeneous matrices, these tumors, any heterogeneity, I would definitely be thinking about biopsy. Low threshold for it. We've had patients referred for radiotherapy, but they look like ETMRs. They turn out to be ETMRs. And that differentiation has to exist. I think the DIPGs are fairly typical on radiology, and that is why radiologists are expected to make that diagnosis.
Okay, thank you. And my second question is related to response assessment. You stressed out in your lecture about that volumetric changes, as Rapno emphasizes. They're not. We can look at other biomarkers others than volumetric changes. So what do you use in your daily practice? You have shown histograms, ADC histograms, but do you use perfusion, any other tools that you can increase your confidence in the diagnosis of the response?
On a practical day-to-day basis, I do draw a region of interest on the ADC to see if the numbers are coming down or are they going up. If the tumor is becoming darker and darker, I don't think it's doing well. Second thing is in fact, none of us go around measuring volumes on a regular basis. We make an assessment of what the volume is doing. We do ASL perfusion, but I think all this only matters when you have a serial retrospective analysis of what the tumor did. I personally think in real time, pseudoprogression cannot be confidently diagnosed in this tumor. We have to use the retrospectoscope, repeat the scan, and see what the patient is doing clinically. We don't get pseudoprogression right in prospective real-time imaging reporting. Nobody does. The other thing to add is, as in the adult practice where your dynamic perfusions make a big difference to the outcomes, it doesn't seem to work very well for children anyways. But I'm happy to be corrected wrong. Leonardo, you can share your own practice and tell me what you're doing in São Paulo.
Here in São Paulo, we have been using most of the time ADC values is that what we have been using, but most of the time in a visual fashion, and we also use perfusion, sometimes ASL or even DSC perfusion. But as you said, it's very reassuring to hear from you that this kind of this notion that you need to be retrospective to sometimes pick up pseudoprogression, because this is really something that is difficult, and sometimes oncologists they want this answer in real time. And so it's good to hear from you that you guys also have this feeling that you need to take a look backwards and then figure out what's going on with the tumor. It's very, very, very important notion to be stressed out.
We share that experience, definitely. And that's why I started looking at textures, and going back to the axial T2 might be useful.
That's nice. Thanks, Kish. Very good lecture.
Very good to see you.
Thank you, Dr. Kish. Thank you, Dr. Leonardo, Dr. Leandro Lucato. Dr. Elder, do you have any question?
Hi, good night. Can you hear me?
Yes, we can.
Yes.
Dr. Mankad, I should congratulate you. This lecture was marvelous. And I am a pediatric cancerologist. I treat these patients, and it's been harsh. Yeah, they have very poor prognosis. We do our best, but we can do so far. Well, I have a patient, a teenager girl, that has a beta lung tumor, and it has an image very typical of diffuse midline glioma, and has involvement of brainstem as well, mesencephalon, pontine, and even medulla. She has underwent radiotherapy, and she recently has had a clinical progression. And in the image, we noticed something very unusual. Well, at least for me, I don't remember seeing that. There was a focal modification in the ADC, only in a region, in a focal region of the thalamus. One of the thalamus, we have a very dark ADC level, and not in the rest of the lesion. But she has really had a very rapid clinical worsening. So my question is, have you seen this kind of pattern, focal or heterogeneous ADC modifications in diffuse midline gliomas?
Yeah. First of all, focal changes in ADC can happen with progression. It is telling us that the mitotic index of the tumor has gone up. Of course, sometimes when you have frank necrosis, those areas can also show low values. But I think you're not looking at necrosis. Perhaps it's not showing any enhancement or hemorrhagic change. But I have seen increasing mitotic activity when the tumor is radioresistant, not responding, and that's telling us that the tumor is progressing away in the background. It's quite commonly seen as focal little areas, not the whole thing, but focal areas that kind of increase in size.
Okay, thank you. This was mainly the only one modification in the image. The tumor is, well, we have enlargement of the brainstem as a whole, enlargement of the thalamic region, but this image, this volume, has not modified. Only this heterogeneity in AGC, and she's not good.
I also have heard about a case. It was not our case. This was from Toronto, where Professor Shroff said that they had a case of diffuse intrinsic pontine glioma, where after 2 years, the tumor completely goes away. You can't see much in T2. There's no mass effect, but the child died the next day.
Oh my gosh.
I have not seen this case, but this is from personal communication. And I can see why, because the survival is universally around 11 months
Yeah.
on an average.
Okay, thank you.
We should all work on these tumors and try to help our neurologists, oncologists, and surgeons, actually. Dr. Aslan has a question. I think he's asking in the chat box.
Yes, we have a question in chat.
He has to ask his question first. He's probably typing. Thank you for giving your time to come and join this session, and thank you, Pablo, for organizing it. Looks like you have a nice little club of very interesting people joining you.
Thank you. Thank you, Doctor.
Dr. Aslan, if you want, you can email me your question as well later. Oh, here we go. We see diffuse midline gliomas in the pineal region. They enhance more than typical pontine glioma. I have seen, I think, a couple of diffuse midline gliomas in the pineal region. And yes, they do enhance more than the ones in the pons. The pons ones typically show very limited enhancement. Yeah, it's a good observation. I agree. But also in the pineal region, those diffuse midline gliomas are quite low on T2 as well as the diffusion.
I have one case, but in adult, diffuse midline glioma, but not pediatric case. I have one case, but in adult.
All right.
42 years, woman. Dr. Elder, do you have case to show Dr. Kish?
Well, I have one case. If can I?
Dr. Kish, do you have time to show?
Yeah, sure. Go ahead. Show it. Definitely.
Okay.
It'll be nice to see your case.
Let's see if I can.
I have all the time. It's 11 p.m. It's only going to be 12, so nothing to do.
Thank you very much.
I'll share my screen. Okay, I think it's sharing. And can you see the?
Yes.
Okay. Let's see if this. Let's go. This is a case of a 14-year-old boy with a brain tumor, and very typical clinical signs: cranial nerve palsy, pyramidal tract dysfunction, tetraparesis, ataxia. He had 2 or 3 months of symptoms, no family history, no previous disease or conditions, and he had a biopsy. These are the images on Excel, T1 with contrast. You can see the very little enhancement. There's a pontine enlargement, more on the cerebropontine peduncle, but we can see the engulfment, partial engulfment of the basilar artery. On T2, it's more of a typical image. We have a shadowy signal, a shadowy white signal in the bones and the cerebropontine peduncle, and no sign of low ADC level. And the pathology of this tumor was, at first glance, a diffuse extrastoma. The pathologist said it seemed like a gymnostic extrastoma. However, and the Ki-67 was low. It seemed like a grade 2 diffuse extrastoma. However, there was IDH1 negative, P53 negative, and we made the detection by immunohistochemistry of methylated histone-free, and was negative. This absence of 3-methylated histone-free on the 27 lysine residue is very typical of histone-mutated glioma, diffuse midline glioma. So we have diagnosed this case as a diffuse midline glioma. Unfortunately, it's a tumor most frequent in children. We have a lot of midline locations, but one of the most known is the pontine, known as DIPG, diffuse intrinsic pontine glioma. 10 to 50% of all pediatric brain tumors are histone-mutated diffuse midline gliomas. It's not really a good group of tumors. Age is 6 to 7 years, median age. In children, there's no predominance of male or female sex, but in the adult case, there are more male patients. However, we can stress one information that you can find in the NCI sites. We have only 1% of adults malignant brain tumors that are histone mutated diffuse midline gliomas. However, when we put side to side children and adults, we can see a lot of adults because we have much more adults with brain tumors. So half of diffuse midline glioma patients happen to have more than 15 years old, if you count all the adults. However, if you count only GIPG, it's really virtually a pediatric disease. GIPG is very, very rare in adults. This is another case of a very typical image of GIPG with that basilar artery engulfment sign. There is really very typical sign. And why do we have these tumors? Well, this histone mutation, the most frequent histone mutation, the one that really renders some of the glial cells prone to transform into this tumor is this substitution of a lysine residue by a methionine. H3K27M. We have many isoforms of stone 3, stone 3.1, 3.3, 3.x, a lot of. Each isoform, each neuronal cell and glial cell, each cell of our organism has a lot of isoforms of histone 3. But only one isoform mutated can change all the methylation of all the other isoforms in a cell. Why? Because the mutated H3 histone acts as an inhibitor of the EZH2 protein. There is a lysine methylase in the polycomb complex 2, the PRC2. PRC2 is a complex of many enzymes, many proteins that acts as a molecular machinery, and it regulates the methylation of stone 3 in a cell. So when we have this mutation, we shut down this machinery. We do not have methylation of the 27 lysine residue in H3 stone, any of the isoforms. This mechanism is very specific for this residue. There are other machineries, molecular machineries, that are responsible for other sites of many sites of methylation in histone 3 and other histone proteins. But in this case, this molecular machinery is very specific for this site. And it has a very specific gene derepression signature that is specific for cell type. Not every cell in our organism will have the same methylation modification with this mutation. We have a lot of sites a lot of potential sites for methylation, acetylation, ubiquitination, and other kinds of epigenetic mutations in stone proteins. And these modifications do two things. They enhance or they abolish messenger RNA synthesis, so the genetic activity. Specifically, the K27 residue in the H3 stone, its methylation can have most times a repressive signal. Sometimes it can be a permissive signal, but most times it is repressive. So when the cell loses the methylation of this histone residue, it will de-repress a lot of genes because this signal is repressive. It shuts down a lot of genes. For example, oncogenes. So we can initiate the synthesis of a lot of genes related with cell proliferation. And this modification happens in very specific pontine oligodendrocytes, and this modification will give rise to the GIPG. This is a very typical survival curve for GIPG. It's for our patients in our hospital, 62 patients in a period of 10 years, and we have this. Unfortunately, only a little more than 9 months of median overall survival. This is the experience of everyone in every point of the globe. Treatment is very difficult because we have drugs that can act in vitro. We have drugs that can kill GIPG cells in vitro, but these drugs cannot reach the site. The pons is very protected by blood-brain barrier, and this tumor is very infiltrative, so it will not disrupt blood barrier. So what can we do? Dr. Suedan and his group in New York, in the Columbia Presbyterian Hospital, they have developed since 2002 a technique of convention-enhanced delivery that will inject a drug directly into the pulse. They have managed to complete some phase 1 trials. Unfortunately, the survival of the patients was not modified. We don't know exactly why, but it's still in progress. It's still work in progress. Well, someday we will have something. I have faith. And with my faith, we end.
The convection therapy was tried here in London as well, and the pandemic basically destroyed the trial quite badly because they had to stop. They had some good results early on, but the long term is not known. But they were picking up patients that were already quite terminal with diffuse metastatic diseases. It's unclear as to what impact it will make when done early.
Well, I think we have a lot to learn about histone epigenetic modifications and epigenetic modification as a whole. So we have, I think we're going to have more knowledge, and I hope some answer to treat these patients.
Thank you very much. The select group in the meeting. You, Dr. Krish, you are a great international educator. Thank you very much. Your lecture is very amazing. Thank you, Dr. Leonardo Furtado. Thank you, Dr. Leandro Lucato, Dr. Elder Felix. Thank you helping us in night. You have any question?
Thank you, all of you guys. Thank you, Dr. Kish. Good night for all.
Thank you, Leonardo.
I'd like to hear from an update from the lockdown. How's everything going there?
Here in London, we are isolating in our places, no mixing of homes and no meeting friends. Shops are all still closed. Only the cafes are open. And at work, we've tried to keep one person on site, so I don't even get to see my colleagues. So I'm just falling in love with myself. That's all.
Okay. You received the vaccine already?
I got dose 1. I was supposed to get dose 2 like tomorrow, but now there is a deficiency of the vaccines.
Oof.
But maybe soon.
Good.
Did you all get the vaccines there?
Yeah, it's the same case here.
We got those 1 and waiting for the second one.
And now we have the South African variant that's come up as well.
Yeah.
South
We have a
Africa.
new one in Brazil also.
We have 2. Manaus and Rio de Janeiro has another variant.
Yeah.
Wow.
Well.
I'm going to travel to Fortaleza. Pablo has invited me as soon as possible.
Yes.
That'll be good.
I'm sure there'll be a few stops on the way there from here.
Of course. Thank you very much,
Okay.
everybody.
You guys.
Dr. Nina,
Thank you very much.
Dr. Leonardo.
See
That was a
you.
marvelous talk.
Bye.
Take
Bye.
care. Stay safe.
Be safe,
You too.
everybody.
Take care. Stay in touch, Leon.
Be safe, my friend Kish. Bye-bye.